Rheumatic Heart Disease by Dr. Emmanuel Rusingiza.
My name is Emmanuel Rusingiza. I'm a pediatric cardiologist at Kigali University Teaching Hospital, Rwanda. I'm going to talk about the diagnosis and management of rheumatic heart disease.
Types of valvular diseases.
Rheumatic heart disease is the result of damage to the heart valves, which occur after repeated episodes of acute rheumatic fever, although initial attacks can lead directly to rheumatic heart disease. Early diagnosis of rheumatic heart disease is very important so that secondary prophylaxis can be started as soon as possible to help prevent the progression of the valve disease. Echocardiography is an essential tool to confirm the diagnosis and to detect any progression of the valvular disease. So now, what are the types of rheumatic heart disease? The types of valvular rheumatic heart disease are the following. The mitral valve is the mostly affected in over 90% of cases of rheumatic heart disease. The next common affected valve is the aortic valve, and usually disease of the aortic valve is associated with the disease of the mitral valve. The tricuspid and pulmonary valves are rarely directly affected, but the tricuspid regurgitation may occur in advanced mitral valve disease, especially when there is severe pulmonary hypertension. So the valvular lesions include the mitral regurgitation, which is found most commonly in children and young adults, the mitral stenosis, which represents longer-term chronic changes to the mitral valve, more commonly seen in adults. Older children can present both mitral stenosis and mitral regurgitation. Aortic regurgitation is not uncommon, and aortic stenosis is almost never seen as an isolated lesion.
Symptoms.
The symptoms of rheumatic heart disease depend on the valve lesion and its severity. Symptoms may not show for many years until the valve disease becomes severe. Initial symptoms of rheumatic heart disease are the symptoms of early heart failure, which are the breathlessness on exertion, general weakness, cough, and sometimes hemoptysis based on the level of the pulmonary edema, orthopnea, paroxysmal nocturnal dyspnea, peripheral edema, which can be generalized afterward if there is no intervention. Signs of chronic malnutrition may occur as complication due to long-term heart condition. Specific symptoms include palpitations in case of atrial fibrillation, particularly with mitral stenosis, and in this case there is an associated risk of embolic events. Stroke when there is cerebral embolism in case of atrial fibrillation and/or infective endocarditis of the mitral or aortic valve, but also sometimes severe mitral stenosis can cause stroke. People with aortic valve disease may experience syncope in addition to heart failure symptoms.
Physical examination.
Physical examination is a very important step, and clinical examination should include assessment of severity and complications, including signs of heart failure, which are tachypnea, tachycardia, edema, raised jugular venous pressure, hepatomegaly, lung crackles, and so on. The presence of atrial fibrillation and the presence of stroke must be assessed as well. The auscultation for the mitral regurgitation reveals a pansystolic murmur heard loudest at the apex and radiating laterally to the axilla. Mitral stenosis reveals a low-pitched diastolic rumble, heard best at the apex. In case of aortic regurgitation, there is a diastolic blowing decrescendo murmur, best heard at the left sternal border with the person sitting up. In case of aortic stenosis, the murmur is loud, low-pitched mid-systolic ejection murmur, best heard in the aortic area and radiating to the neck.
Investigations.
The investigations include electrocardiography, which is essential to determine the cardiac rhythm and other abnormal patterns. Chest X-ray helps to assess the size of the heart chambers and to detect pulmonary congestion. Echocardiography is here the gold standard exam. It confirms the diagnosis and detect any rheumatic valve damage, help determine its severity, and assess left ventricular function. Additional investigations include FBC, electrolyte, especially sodium and potassium, renal function test, and liver function test. Let us insist a little bit on the echocardiography. In 2011, the World Heart Federation has developed the criteria to make echocardiography reporting simple, reproducible, and consistent worldwide. The echocardiography criteria helps in screening of rheumatic heart disease in school children, and it is based on morphologic features and pathological regurgitation for the mitral and aortic valves. There are 3 diagnostic possibilities based on the echocardiography criteria, which are definite rheumatic heart disease, borderline rheumatic heart disease, and normal valves. These are some few examples of echocardiography images. This slide shows a parasternal long axis view, and you can see very well the left ventricle, the left atrium, the aorta, the mitral valve. Here, the mitral valve looks thickened, and the anterior leaflet, especially on the tip, looks thickened. The posterior one looks retracted. This is a 4-chamber view or apex view, which shows the thickness of the mitral leaflet and chordae, but mostly you can see a significant mitral regurgitation, which is posteriorly directed jet and typical for rheumatic valvular disease. This slide shows the long axis view of the heart, which shows the thickness of the mitral valve leaflets and the aortic leaflets. This patient presents severe mitral stenosis, aortic regurgitation, and aortic stenosis. This is another image of long axis view, which shows the Doppler on the aortic valve, and you can see very well the jet of aortic regurgitation in red.
Management.
The goal of the management of rheumatic heart disease is to prevent disease progression and to avoid or at least delay valve surgery. Secondary prophylaxis for prevention of recurrent acute rheumatic fever is the main strategy. The key elements of the effective management of rheumatic heart disease are initial assessment, education and referral to a medical or heart specialist if applies. In case of heart failure, it is recommended to admit the patient for bed rest. And treatment of heart failure with diuretics and ACE inhibitors. Management of atrial fibrillation with digoxin and anticoagulation. Regular medical and echocardiographic review. Secondary prophylaxis is very important to prevent the recurrence of acute rheumatic fever, which come to damage more the heart valves. The infective endocarditis prophylaxis is very important before dental and surgical procedures. It is also needed to plan for regular dental care and also contraception, especially for female adolescents. The complications of rheumatic heart disease depend upon the affected valve. They are heart failure with severe pulmonary hypertension, infective endocarditis, stroke, atrial fibrillation, chronic malnutrition, and ventricular dysfunction. The treatment of congestive heart failure depends upon the nature of the valvular lesion. When it is due to severe mitral and aortic regurgitation, it is important to admit the patient for bed rest, give anti-failure medications, but also consider the nutritional support. When the heart failure is due to severe mitral stenosis, the treatment is done by diuretics, beta blocker, depending upon the school, aspirin to prevent intra-atrial thrombus and stroke, and warfarin is absolutely indicated in case of atrial fibrillation. The indication for heart surgery is determined by the severity of the symptoms, the evidence that the heart valves are significantly damaged, the left ventricle chamber size, and the function. The types of valvular surgery include valvular repair or valve replacement by either a bioprosthetic valve or a mechanical valve. Factors to absolute contraindication to valve surgery are poor left ventricle function with valve regurgitation. Severe pulmonary hypertension may pose an unacceptable risk for cardiac surgery. Good nutritional status improves post-operative outcomes. Anticoagulation is indicated for patients who undergo valvular replacement. The commonly used drug is coumadin or warfarin. The treatment with warfarin needs to be monitored following replacement with mechanical valves. Good anticoagulation management requires standardized anticoagulation measurement using the international normalized ratio called INR. This table summarizes the indications, the goal of INR, and duration of anticoagulation therapy. As you can see, most of the goal for INR is between 2.5 and 3.5. And when there is a mechanical valve, the duration of therapy is lifelong. After cardiac surgery, it's very important to plan regular long-term follow-up. The conservative valve procedures like valve repair require close observation to detect restenosis or a recurrence of valve regurgitation. Ensure secondary prophylaxis is administered regularly using benzontine penicillin G IM every 3 to 4 weeks to prevent recurrent attacks by acute rheumatic fever. It is also important to monitor the left ventricle and prosthetic function during the follow-up. Now, endocarditis prevention is another important point because infective endocarditis is a serious complication of rheumatic heart disease and may also occur after heart valve surgery. This uncommonly occurs during dental and surgical procedures, but often the source of the infection is not clear. Infective endocarditis most commonly occurs in the mitral or aortic valve, since these are the most commonly damaged heart valves. Thank you for watching.
Please help us improve the content by providing us with some feedback.